You're listening to the Pharmacy Podcast Network.
Hello, this is Ralph Lombardo with Avadim Health. You are listening to the Pharmacy Podcast.
Pharmacy Podcast Nation. This is the founder of the Pharmacy Podcast Network, Todd Uri, and I am thrilled today bringing back a third-time guest to the Pharmacy Podcast Network. The one and only Dr. Jeffrey Fudin is joining us today. He was with us last time when he was talking about opioid prescribing guidelines. We really appreciated his insights. Before that, he actually was on talking about the pharmacy impact on the opioid epidemic. Today is a very special opportunity bringing Dr. Fudin back to the Pharmacy Podcast Network because we have another guest with us that I want to introduce before we get going. Mr. Ralph Lombardo is with Avadim Health, and Avadim Health is the founders, developers, distributors of TheraWorks Relief, which has been a tremendous supporter of the Pharmacy Podcast Network. Something very special to me, if the Pharmacy Podcast Network listeners don't realize, I work for a large addiction recovery organization throughout the country in 22 states with 80 different treatment centers called New Season. And I am tasked with finding funding for patients who can't afford their treatment. And I am excited to be able to bring a myriad of topics to the Pharmacy Podcast Network surrounding the opioid epidemic and how pharmacy is going to help this crisis as we move forward. So, Dr. Fudin, welcome back to the Pharmacy Podcast.
Thank you very much. Glad to be here.
Ralph, it's your first time on the show, and welcome.
Thank you so much. It's an exciting opportunity for us to be a part of such a great asset in the pharmacy community.
Thank you, Ralph. And just to start out, Ralph, just give us a little background on yourself, a little bit about Avadim Health, and then we have lots of questions.
Sure. I am a dietitian by trade, and in the 80s became involved in the pharmaceutical industry. Spent a good amount of time with Wyeth Laboratories, and then became an employee of Purdue Pharma. Spent the majority of my career there, and in 2009, I left Purdue Pharma to join Avadim Health, a life sciences company that is dedicated to research and find and create innovations for infectious disease, neuromuscular health, and wounds. And very excited to be a part of the Pharmacy Podcast.
Dr. Fudin, just in case the listeners haven't heard your other two appearances on the Pharmacy Podcast, let's give a little background in you as the founder of PainDoctor.com. That's PainDr.com. And just a little bit about your background too, Dr. Fudin.
Sure. Well, I guess I'll start with the PainDr.com website. I developed that site, started to develop it, I'm going to say probably 17 years ago or so, a long time ago. And the site has a lot of information, quick references for pharmacists, medical providers, and also for patients on it. Thousands and thousands of downloads by pharmacists of the various reference materials. I have a very, very active blog on there, which it's actually uncanny. Some of the blog responses have developed into sort of communities amongst patients and providers. Some of the posts have over 1,000 comments on them. So I spend a considerable amount of time on that. I also have a company called Remitigate, and that's a software development company that focuses on opioid safety. So we have one platform that predicts risk of opioid-induced respiratory depression over the next 6 months based on a number of attributes of the patient, various disease states, basically you check these things off and it develops a progress note. We also have something called UrinTel, which helps clinicians, including pharmacists, to interpret urine screens correctly that are done by immunoassay. I do have a clinic in a federal VA facility where I do direct patient care and oversee a residency program. And then in my spare time, I do a lot of expert witness work, which is unbelievable how it has increased with this, the issues around opioids, appropriate prescribing, and some of the risks. So I'm kind of a busy guy, but I do enjoy the space that I'm practicing in. And for me, it's, a lot of people are sort of typecast me into the opioid world, but I do go outside of opioids. We get involved a lot with alternative therapies, monitoring pharmacogenetics, and offering medications other than opioids and or in addition to opioids. So that's a bit of my background.
It's interesting how you don't necessarily want to be, quote unquote, typecast into one sector of healthcare, but this time in what's happening to the nation, your expertise, Dr. Fudin, is so much needed. So I'm sure that's very much part of the reason of your demand to go speak at different places on the epidemic and how pharmacy can have an impact to it. But just general information and factual information, even from a clinical perspective, is so important at this point. That turns to my first question really for Ralph, and that is, as a business guy, someone who is supporting the ability to expand your services and some of the education that you guys sponsor, tell us a little bit from your perspective in Avadim Health's perspective, your views and initiatives and strategy surrounding the opioid epidemic.
Well, we have a proprietary methodology that we employ before we ever bring a technology to market. And it's enveloped in the name TheraWorks. And for us, we identify therapeutic interventional gaps in the marketplace. And that's what the Thera of the TheraWorks stands for, through an exhaustive process. And then we conduct high-quality evidence-based research with academic teaching institutional partners to demonstrate that the products work. And we uncovered a significant gap in care in the marketplace amongst Americans that suffer with nocturnal cramps and spasms, and patients that suffer with symptoms associated with restless leg, and in particular, patients that are demonstrating refractory response to dopaminergic medications. The numbers are staggering, and we believe that many of these patients are the unheard sufferer. 29 million Americans suffer daily with nocturnal cramps and spasms, according to the American Family Physician publication, August 2012. So the number's probably even larger now. And 24 million Americans, according to the National Sleep Foundation, 1 in 10 adults suffer with symptoms associated with restless leg syndrome. And when you think about such significant demographics, and we only have one class of medication for the restless leg sufferer that's been approved for that condition, the dopaminergic class of medications, we thought and saw there was the need to do research for topical, non-centrally acting agents. And we did exhaustive research and studies in the nocturnal cramp and spasm sufferer, as the pharmacists listening will know and recognize, Qualiquin, which was indicated for the treatment of malaria, the FDA, initiated a REMS because of, hematologic, death. And so these patients are left to eating more bananas, making sure they drink tonic water and hydration. And so we have come to the market with the approach of using locally acting, non-centrally acting technology to reduce the symptoms associated, with these conditions.
Dr. Fudin, with your specialization on pain, you're seeing it firsthand, and before this really became an epidemic per se, in opioid overprescribing and 70,000 drug overdoses and more, finding out through data from the Center of Disease and Control Prevention. The 2017 metrics have just been updated. Pain is something that humans must deal with in different variances from scales, I guess, from 1 to 10. And much of it can be controlled probably by stretching and eating right. And however, there's always a time that you're going to need something else, maybe an Advil, maybe something, a little bit stronger, depending on what your physician and pharmacist are directing you towards. But what kind of tools are you reaching out to, and should other medical professionals being reached out to that is non-opioid, and what have you seen in your consultations with patients with regards to pain?
Okay, so a lot of questions there. I'm going to start by clarifying one of the statements that you made, because I think it's really important. You mentioned the opioid epidemic, and in the same sentence talked about 70,000 deaths. And so I just want to point out that number is often quoted in the same sentence. And I know that you know what that number means, but just for the listeners, I want to make it clear that 70,000 deaths includes all drugs, not just opioids. And so when that quote, you sometimes hear 64,000 or 70,000, it involves anticoagulants, antidepressants, skeletal muscle relaxants, all sorts of drugs, including benzodiazepines and opioids. So I just want to clarify that. Obviously, we see a lot of issues with pain, and usually it's more than one pain in the patients that I see. So it's not just like chronic back pain or muscle spasms or cramping, radicular pain or neuropathic pain. It's usually a combination. And so, when you ask about some of the non-opioids, we do use non-opioids first. Most of the patients that refer to our clinic are already on opioids, but they're not all on opioids. But I will say this. I think that particularly when we're talking about muscle cramping, we have to remember that most of the drugs that are used for muscle cramping can cause significant sedation. And while most of them, not all of them, but most of them really have no contribution to respiratory depression per se as single agents, when you start combining them with opioids, that's where we see problems. And, we hear a lot about, the dangers of combining benzodiazepines with opioids and the increased risk of opioid-induced respiratory depression and possible death. But what we don't hear a lot about is combining other sedative hypnotics with opioids and how that can increase the risk. And just for an example, something I think is very common, pharmacists see all the time, is a prescription for amitriptyline, even low-dose amitriptyline, let's say at bedtime, for maybe depression and sleep. And then you may also see a prescription for Flexeril or cyclobenzaprine. The truth is that both of these drugs are tricyclics. They chemically are identical. The only difference is an extra single bond in the middle ring of the triple ring. It's the only difference. And so when you start combining things like cyclobenzaprine and amitriptyline, which are essentially the same drug, and then you add things on like tizanidine and gabapentin, and who knows what else. That's where we really start to see problems. I think that skeletal muscle relaxants in general may not be great when you consider the risks of some of these drugs versus the benefits. I mean, they're marginally effective. I actually did wrote a comprehensive review article on skeletal muscle relaxants earlier this year, and we outlined pretty much all of them. And, when you think like carisoprodol is a disaster, or soma, absolute disaster, because it gets metabolized to methylbenate, which was like a precursor to the barbiturates. It is very, very toxic and addicting. So, I think that if we're talking about skeletal muscle relaxants, they can be pretty toxic. You mentioned ibuprofen. And yeah, I mean, the anti-inflammatories may be okay for muscle cramping, but generally they're not that great unless the muscle cramping is a result of connective tissue disorder with a lot of inflammation that's secondarily causing the cramping. But for muscle cramping in general, NSAIDs and acetaminophen really don't work that well.
If I may add something to Dr. Fudin's comments, we work extensively with the long-term care community. And Dr. Fudin, I'm sure you're familiar with the Beers list of medications.
Oh, yeah.
Seniors over the age of 65, all of the muscle relaxants, methocarbamol, the cyclobenzaprines are listed. Even the antineuroleptics like pregobol and gabapentin are listed as either avoid or high-risk medications in seniors. And I think it's the reasons are, as you've outlined, concomitant use with other centrally acting cognitive impairing agents increase the risk of injury, and primarily these should be used very sparingly. It's one of the reasons that we're looking for topical non-systemic solutions so that we can spare the need or maybe limit the dose requirements for patients that have, significant disease. So we see a great opportunity to spare, the exposure risks for seniors.
So, Ralph, I'm thrilled that you brought this whole issue with the Beers criteria, because in particular, things like amitriptyline and cyclobenzaprine, they are disasters in elderly patients, and they're listed on the Beers criteria. But I think that those particular drugs are even worse compared to things like methocarbamol. You mentioned the gabapentinoids. So the gabapentinoids are listed on the Beers criteria, not so much because of sedation, but more because of confusion and risk of falls. Whereas the other drugs, the cyclobenzaprine, the amitriptyline, and the tricyclics in general, are very, very anticholinergic. And the anticholinergic activity, of course, causes sedation, risk of falls, achlorhydria, which elderly people have to begin with, and also increased risk of constipation and dry eyes and urinary retention. All problems that these patients have. So I feel like, the TCAs and cyclobenzaprine are a disaster, especially in the patients we're talking about.
Yes, sir. We're in a significant, what I would call final stage discussions with the larger close provider pharmacy organizations, where, pharmacy consultation can open up the opportunities for increased education. Centers for Medicare Services implemented a new quality measure and standard for homes that have patients on more than 2 centrally acting agents where risks of falls and injury occur. So we're working very closely. If we can spare some of the need for these medications, we may spare the risks of falls and improve outcomes for our seniors.
Right. And you brought the CMS guidelines. So you're probably aware that as of January 2019, just a few days from from this interview, that they're going to implement these new guidelines, which are going to require soft and hard edits by the pharmacist to work collaboratively with prescribing clinicians. So if the patient is on up to 90 milligrams of morphine equivalent, the pharmacist needs to contact the provider to make sure that it's justified. And when the patient, so this is like if they're on 90 milligrams or more, but when they get to 200 milligrams, there's a hard edit. The pharmacist cannot fill the prescription until they contact the provider and get justification that it's warranted. So that's going to be a lot of phone calls between pharmacist and provider for sure.
Yes. We get caught in the middle oftentimes with discussions regarding chemical restraints, especially when seniors have nighttime or nocturnal events. And so we see this as a real challenge for the healthcare industry to provide solutions that perhaps aren't prescriptive, that have a significantly broader therapeutic, safety threshold. And it's a real challenge to the industry. What can we do to improve and lower the risks, for these seniors and community dwelling seniors, not just institutional seniors, but community dwelling seniors that are still, trying to thrive, live active lives.
Dr. Fudin and Ralph, let's take a short break and listen to a message from our sponsor, TheraWorks Relief, and we'll be back in 1 second.
If you or your patients struggle with muscle cramps, spasms, soreness, or restless leg syndrome, you're going to want to hear about our non-opioid TheraWorks Relief. TheraWorks Relief is a clinically proven and published locally acting topical solution that prevents and relieves muscle cramps, spasms, and soreness in the legs and feet. In a research study including patients diagnosed with restless leg syndrome, TheraWorks Relief was shown to reduce symptoms commonly associated with accompanying RLS, including muscle cramps and spasms. Muscle cramps are reported as a side effect of hundreds of prescription medications, from intravenous iron sucrose and conjugated estrogens to statins and diuretics. By managing muscle cramps, TheraWorks Relief supports adherence, helping patients stay on important and often life-saving medications. TheraWorks Relief comes in an easy-to-use, fast-absorbing, non-greasy foam that can prevent muscle cramps and spasms with just a few simple applications a day. To learn more about TheraWorks Relief, go to theraworksrelief.com and click on the Healthcare Professional link.
Hey, welcome back to the Pharmacy Podcast Nation. I'm excited to have Dr. Fudin and Ralph Lombardo on the podcast with us today. It's part one of a part 3 series on a myriad of different topics under the guise of pain management and the type of tools that are out there for consultant-type pharmacists, which is a growing field of pharmacy, which I'm excited to see grow. We're talking today with Dr. Fudin. I was listening to both of you talk earlier in the interview, and I always think of innovation and how pharmacists are gaining much from data, and how data is really teaching pharmacists to make assessments in consultation in senior care pharmacy and specialty pharmacy, depending on the disease state. Dr. Fudin, what kind of data could you get from an organization like Avadim Health that could help you assess a macro population per se, or actually dig down into specific cases that you're currently consulting on?
That's a great question. I think that it would be nice to see with their product for muscle cramps how it has diminished the use of prescription opioids, or even non-prescription, not prescription opioids, but prescription medications in general. Could be opioids, but I'd be interested to know how their product has impacted on the reduction of prescription for skeletal muscle relaxants. That'd be very important. I think that we could extrapolate some of that data to look at adverse outcomes, risk of falls, sedation, and risk of various adverse events, adverse drug reactions, and that sort of thing. So If we could get some of that data, that would be phenomenal.
Ralph, what type of partnership build-outs and things do you think Avadim Health might be interested in doing, and what kind of data have you guys already gleaned from the TheraWorks Relief product?
Well, thank you so much for the question. We've done numerous studies. We did a study with the University of South Carolina in athletes initially, and showed a substantive response in athletes who crossed their cramp threshold. And we were able to not only mitigate the acute episode, but then prevent the rebound episodes where even electrolyte and fluid replacement at rate of loss were shown to not prevent the rebound episode in a cramp-prone athlete. In our studies in restless leg, we partnered with 3 professors of medicine at Brown University and were able to identify patients who were refractory to dopaminergic medication, who were experiencing dose-limiting adverse events. And I mean, some serious adverse events, including syncope, where the addition of our topical muscle relaxant reduced the incidence and severity of symptoms over 50%. And I can imagine physicians are looking for solutions, and when the patient is experiencing severe adverse reaction, they can't titrate the medication, and so they add on, which can lead to what Dr. Fudin was speaking of earlier, where you have drug-to-drug, potentiated, what I would call potentiated adverse response. And so we've done pretty exhaustive work in patients that are chronic sufferers, and a little in the acute setting with athletes, where we could control the delivery of our technology and then the measurement. And so we would be very interested in partnering in the pain community, where many times or oftentimes muscle relaxants may be the first prescriptive medication the patients receive because of the desire to prevent crossing the narcotic bridge. As we all know, once we cross that bridge, many times it's very difficult to come back.
So, Ralph, I got a question for you.
Yes,
is there, with regard to TheraWorks, is there any systemic absorption of any of the ingredients in the formulation?
A great question. To date, we have not seen any systemic adverse, related side effects. We do get local side effects. Every once in a while, we'll get a report of skin reaction. About 40,000 new patients per week are being introduced to TheraWorks Relief as we speak, and we typically get 1 to 2 reports per week. We have a very exhaustive pharmacovigilance program, and we get about 1 to 2 adverse event reports per week, mostly local and skin. And so, we've done randomized controlled crossover design studies to measure some of the mechanisms of action and versus placebo, and we do not see evidence of systemic effects.
Okay, so let me rephrase the question. So I understand that you haven't seen adverse reactions as a presumed result of systemic effects, but the question's a little bit different. Have you actually measured systemic blood levels of any of the ingredients within the product? For example, magnesium, sulfur, grapefruit, anything like that?
We haven't measured blood, but we have measured deep tissue response in a crossover design, and not see any evidence that the product is being absorbed and causing activity in other parts of the body.
Okay, so the reason I asked that question is for the benefit of the pharmacists that are listening, because I don't want them to misunderstand or misinterpret.
Sure.
So, as you may or may not know, grapefruit is a very, very potent inhibitor of cytochrome 384 enzymes, right? And so there are a number of drugs that undergo metabolism by that enzyme, and one of the most common drugs in the pain space, or I should say two of the most common drugs in the pain space, are hydrocodone and oxycodone, and also, of course, methadone. So if you were to inhibit the enzymes, the serum levels of those, the active components of those drugs would increase. What I'm hearing from you is that there's no reason to believe that grapefruit extract is absorbed systemically. And if that were the case, then there would not be an issue with drug interactions between the drugs I just mentioned or other drugs that undergo CYP3A4 metabolism.
That's probably the single most common question that we receive from patients. And of course, without, doing the exhaustive systemic assays, we refer them, back to their healthcare professional.
Sure. Yeah.
We don't have any reason to believe that topical application of our citrus ingredient leads to substantive systemic accumulation, but we don't have the reverse of that information as well.
Okay, great.
Ralph, when I heard you mention athletics, I can't help but to think of my godson, Jelani Stafford, who's a senior in high school who has been recruited by Youngstown State University, the Fighting Penguins. He's going to accept a full scholarship from them as defensive tackle, which is quite exciting. And I think of these children, I think of these kids that are in athletics and some of the more simple abilities to manage pain and what they're subjected to early in life, which turns out to be something that they don't learn to deal with and manage more from a natural perspective before getting into some more of the serious effects and impacts of more harsh ways of dealing with pain, including the use of powerful medications like an opioid. But Dr. Fudin, what's your touch with the athletics world, and have you consulted with any collegiate athletes out there?
So I often am contacted by physiatrists, people who are dealing with some of these athletes, for an opinion on how to best approach it, especially because, as you said, you want to limit the use of opioids. And I can tell you that for things like sprains, strains, and contusions, whether it's high school, college, or professional, we would always prefer topical agents. So, for example, topical diclofenac is often very, very helpful for sprains, strains, and contusions. So topical NSAIDs can be very useful for athletes, for anybody actually, particularly with sprains, strains, and contusions. And we really do like to use the topicals when we can. Now, most young athletes can tolerate oral NSAIDs just fine. But the truth is that these topicals work really phenomenally well. And so I feel that if we can give a topical product, we are far better off because the toxicity is much less. And in fact, it drives me nuts that if you look in the package, the professional package insert for the topical NSAIDs, the FDA requires all of the pharmaceutical companies to include the standard templated warning for NSAIDs, GI bleed, cardiac risk, kidney risk, and all that sort of stuff, which is really absurd because if you look at the blood levels that you achieve from topical NSAIDs compared to oral, in most cases, it's far less than 1, usually 0 point or 0.0 point something, so very, very low systemic absorption. compared to oral. So, for example, oral diclofenac, I mean, you could get a serum level of over 100 nanograms per mil at therapeutic doses, whereas if you look at, let's say, topical diclofenac, you're talking about less than 10 nanograms per mil. And then when you consider that 97% is plasma protein bound anyway, the only active amount is that which is not bound to plasma protein. So there's almost no exposure by topical NSAIDs, including the topical NSAID or steroid eye drops. So, I'm a huge advocate of using topicals in these athletes, Todd. And not that we shouldn't or couldn't use oral agents, but I think that we really need to maximize the topical products either first or in addition to oral non-opioids before we move on to opioids.
Dr. Fudin, I have a question regarding the use of topical technologies first. Is there any evidence that leans toward reinforcing topical practices versus oral plays out more favorably, like behaviorally?
Oh, well, that's a great question. I mean, there are. I mean, I'm aware of some general stuff that just the action. Forget about the drug. Just the action of rubbing some kind of solution, gel, or some kind of topical product in the area. That action alone has therapeutic benefit for various reasons. So there are studies that look at that. There are a number of studies that look at topicals versus oral, particularly in elderly patients. With athletes, there are specific studies I'm aware of that have looked at the topical NSAIDs for sprains, strains, and contusions. And there's also studies, they're not all, hunky-dory. There are also studies that have shown athletes that have overused things like methylsalicylate. For example, there's been deaths associated with basically lopping on tons and tons of methylsalicylate and then having athletes wrap them in cellophane and going to sleep and never waking up because of salicylate toxicity.
Jeez.
Well, I mean, we need to look at the good, bad, and ugly, I think. But generally speaking, the studies basically show that topicals can work very, very well.
We have developed a topical anti-inflammatory technology, and we're currently doing work with UPMC, University of Pittsburgh Medical Center, University of Georgia, and Baylor. And we have a dual modality methodology where we're impregnating medical grade compression. We're studying this in arthritis, in arthritic thumbs and knees, and partly because we've identified a pretty substantial gap in this demographic. According to the Journal of Kidney Disease, more than 39% of Americans aged 60 and above have either chronic kidney disease or significantly reduced renal function. And then there are another 2 million Americans taking anticoagulant therapy, both of which do not bode well for oral NSAID therapy. And so, using mechanical compression, using, as you're suggesting, topical anti-inflammatory regimens, can really, support this demographic that otherwise may not have an option other than going down the road of opiate therapy.
Yeah. Gentlemen, this topic and discussion has been absolutely interesting. Sitting back here with my popcorn, listening to you both talk, I could listen to you for another hour, but our listeners are probably either done with their workout or almost on their way to work in our 30-minute time slot. So we're going to have Dr. Fudin back you have our support. I hear there's some other projects coming up that we're going to be talking about. So Pharmacy Podcast Nation, you'll look out for more from Dr. Fudin. If you want to look him up, please do so. You can find him at paindr.com. That's paindoctor.com. Ralph Lombardo, thank you so much for sponsoring this series and the commitment of Avadim Health and what you've done to bring this messaging and education to the Pharmacy Podcast Network. We're having you back on part 2 of the 3-part series sponsored by Avadim Health. So we'll be hearing from you soon, sir.
Well, thank you very much. Thank you, Dr. Fudin. It's been a pleasure to be a part of the network.
And thank you both, Todd and Ralph. It's always great to be on the show.
You guys are very welcome and welcome back at any time. You were listening to the Pharmacy Podcast Network, the Pharmacy Podcast Nation, sponsored by Avadim Health, 3-part series coming up. You can stay tuned more. And as always, thank you for listening to the Pharmacy Podcast.